go on with some questions to the first speaker, Mr. Abruck. Anybody has a comment or a question for Mr. Abruck? And for Mr. Voss? For Mr. Voss, any question or some kind of comment? And for the techniques of Mr. Enrico Gervasi, anybody has to say something? Please.
Hello. What? Your technique is kind of.
Is it?
Yes.
Okay. Just for the others.
Your technique is kind of, I would say, intrapectoral. Intrapectoral one.
Yeah.
What do you do next? You showed us nicely how do you fix the tendon. After this, what do you do?
After this, so rehab. No.
Technically. So now it's fixed.
Yeah. I go arthroscopically. I cut the tendon, and by arthroscopy, I go down and I pull the tendon off, and I will cut the tendon. So it's easy. You have to go down with a portal, that a arthroscopic portal, sometimes a little bit down compared to the standard portals. But you do this. You pull out the tendon, you fix by a needle so the tendon does not goes everywhere when you manage for cutting it at the distal part, but you pull the tendon off from the intertubercular groove. So if there's some inflammatory reaction into the intertubercular groove, you are off from that problem.
Would you consider it possible to take it out by the incision that you have?
Yes, of course. Yes, of course. This because that incision is not really in direct communication with the shoulder and the subacromial space. So if you want, you do that and you close the wound after. The incision is really distal, and you can do a very small incision, and you have not to open the field with a blunt exercise by fingers. You just go there, you put a couple of stitches, and if you don't do this, I did by anchor and so on. If you know, you put a forceps at the level of the pec major, just a little bit medial, and you feel the long biceps kinking. So you can riding by the forceps the long biceps. There you put a couple of stitches and that's it. Absorbable stitches are very cheap.
Thank you very much. Any other question?
I have two questions for Dr. Gervasi as well as
Yes,
the previous speaker, Dr. The one who spoke about the Andreas Voss. Not Andreas, sorry, Anton Ion Roraback. So it is related to the, you showed a wonderful lasso technique by which you do a tenodesis, but you open the transverse humeral ligament and your knot is exposed. So do this patient have similar kind of pain? Because pain is the commonest reason which we moved out from the intra-articular to the inside the groove to subpectoral, now intrapectoral. So we moved down. So do you have a different experience? Because your lasso knot is quite a big knot, plus you are knocked off the transverse humeral ligament when you excise that superficial layer of coracohumeral ligament.
I'll use this mic. I understand, and maybe it's quite a bit controversial, and maybe that's the reason why just because of a feeling that we combine it with this very small acromioplasty, and I'm not sure that is because of the suture really sticking out and the suture irritating. I think if you work in that region, there might be some scar tissue or things like that. So we add the small acromioplasty just to open up a bit the space, just right on top of the position where we did the most of our work. The position where we put the anchor and where we put the sutures. Well, if you do a revision, you know there's always some scar tissue around the region where you worked. So that's for us the reason now we do a small acromioplasty. I'm not aware of any study or publication where a knot in that region would really be irritating. I was just discussing with Antonio. I don't think it's really an issue to leave the groove open with the suture there. I'm not aware of really any scientific based evidence that would harm. So for me to do the acromioplasty is really just to unload that region where no doubt there's going to be some scar tissue after the work that we've done around the biceps. So I wouldn't close the groove. And maybe as I'm just here, maybe just to finalize, because there's so many techniques on biceps, I think the conclusion not to use any implants because we save costs makes absolutely sense. And in that view, there is another technique described by Steve O'Brien, where he just tenotomizes the long head of the biceps and he closes it to the short head of the biceps. So he takes it out and he takes it side to side, the long head to the conjoint tendon. And it's just with one suture, very cheap as well, without any definitive implants. Just to...
Yeah, I think whatever is common is always controversial. Bicep is a very common pathology. I'll ask Enrico, because now we have shifted from the groove to the subpectoral area. Now it is an intrapectoral. And what was his reason why he started an intrapectoral tenodesis rather than subpectoral tenodesis? So do you feel the pain was a cause?
No. This is because all the surgeons are confident with the deltopectoral approach. And the cons that someone says that the pec major can be jeopardized by the incision. I showed before, as you go straight in line with the fibers direction of the pec major, you have no damage because you can make a cut, and if you take the scalpel off, the cut is closed by itself. So it is for a confidence of the surgeons that are not confident to go to the axilla to release the long biceps from the coracobrachialis fascia. So this is for easy.
Thank you very much. Another comment? A short one.
Because you mentioned these without the implant-free techniques. One I have to stress here, like this loop tenodesis, someone showed it a bit, where you take it out. I've been using it for 8 months now. You just take you cut it, you take it out, you do a loop, and you just put it in there. I have to say I copied it from Frank Matterschläger, and I think he's preparing a study on it now. So I just wanted to say as a comment, because you mentioned it.
Right.
I have a question for the group. For those of you who are proponents of the suprapectoral tenodesis techniques, and we've seen a variety of nice demonstrations, what's your experience with groove pain, and what's your approach to those patients with a suprapectoral approach?
Yeah, I know that's a concern, but to be honest, I've learned this technique with Laurent 15 years ago. So we're putting these anchors in for 15 years at that position, and to be honest, of course, not all our patients are perfect. Somebody who's saying that he's got perfect results is not right. So probably we'll have some people with some pain, and from time to time, it's very rare that we put maybe some injection in it and just to maybe get off some of the inflammation. But I think once you get rid of the sliding structure within the groove, which is the biceps, then you get rid of the pain. And if you continue having groove pain, maybe you should look for other reasons do an ultrasound, just see if there's nothing else going on. So I think once you get rid of the sliding structure, as is the biceps, whether it's a tenotomy or tenodesis or at any level, I think, you should get rid of the pain at the groove. So if they're still painful, maybe inject or look for other reasons for the pain. That's my idea.
Yes.
Okay.
Yes, I was thinking about that. But I'm not an American.
Okay.
Okay. It's made for really. It's made for this.
Whoa.
So this is a question for all the speakers, and not only for the speaker, for everyone here. And when I was younger and I started doing biceps tenodesis, I attended Laurent Lafosse and I saw the technique, and the technique was very nice and very easy. And so I am operating in lateral decubitus, so I modified a little the technique and started doing this, the same technique. And most of the patients went well, but there were some patients that they have pain. They still had pain. And many years later, I was visiting Enrico Gervasi, and Enrico is one of my mentors. And it's strange to talk about mentors at 60, but I'm very happy that still learning. So I attended him and I saw the technique, and the technique was extremely easy. And when I came back, I started doing this technique. And so I said, I'm going to lose the problem. I'll solve the problem of those patients that still had pain. And, but still some patients still had pain, even that I have removed completely the biceps from the groove. And moreover, I had some patients that they had pain after an intraarticular tenodesis, so I revised them. And I went to the groove and I revised it to the subpectoral tenodesis. And the tenodesis was perfect and the tendon was fixed well, and I had to cut him and tenodize lower. And I was certain that I have solved the problem. But there are still patients after that they still have pain in the groove. And so any comment, any explanation, any ideas? What is happening? I think that there is something that we don't know about the pain generators in the anterior part of the shoulder.
Well, that was exactly my idea. If you fix it, there's no sliding structure anymore, then you have to look for other means.
Well, I've had cases such as that where I've had to revise a suprapectoral to a subpectoral, and that has solved the problem. There are also some cases that you outlined that where there's still persistent pain. It's amazing sometimes if you have good visualization of the bicipital groove through, let's say, a subpectoral approach, there's profound hypertrophic synovium in the groove that you can extract with a curette or with electrocautery. But if you're using some of these less invasive techniques, I'm sometimes concerned that you may not see that and treat that.
Any other comment, or are we going to make a break now, a coffee break? And we'll be back in 20 minutes. Thank you very much.